very pleasure, and it's my pleasure and glamorous to see all my seniors, our leaders, along with us, and the new younger endocrinologists and physicians to participate in this series of case presentation. It was started around 1 year back with the inspiration by the Dr. K K Pareek sir and Dr. Girish Mathur sir. And with their blessing, this event is going well. And before going for the scientific program, I will request Dr. K K Pareek sir, who is the, I cannot say leader, but he's a father figure for all of us, loving person who loves all of us very well. And whenever I talk to him, I feel at least very good from heart to talk with him. And with his blessings, this program is also going well, and we, the physicians of the Rajasthan, are getting good name and fame with his experts only. Dr. K K Pareek sir, I will request you to say few words of blessings to all of us.
Thank you, dear Prakash, for kind words. Really a pleasure of great pleasure to be on this platform of CME on diabetes. And at the outset, let me put on record the efforts, great efforts made by you, and great initiative taken by Dr. Girish Mathur, the then president of RSSDI, chairman of RSSDI Rajasthan chapter. Really great work done, and this is really a great thing. Those who knows knowledge, they should spread the knowledge to everyone, and this is what you are doing on this platform. Really, thank you so much, and I hope that you will keep it all the way for a very long time. I welcome our dear past President, Dr. Girish Mathur, and uncontested Dean-elect and a visionary leader of API Rajasthan chapter, Dr. Girish Mathur, our loving friend, Dr. Ramchandani, a great honorary secretary of Rajasthan chapter of RSSDI, and I welcome our legend endocrinologist, Dr. Sanjay Saran, Sandeep Tak, Dr. ABHISHEK Prakash, and the case will be presented by a very young endocrinologist, Dr. NITESH Kumar Buddha. I have heard him once in Kota, and I found him a really good orator and a very confident orator. So I hope we'll be greatly benefited by the discussions. I also welcome our all delegates. Thank you so much for joining and making this CME successful. Thank you very much.
Thank you, sir. Thank you very much for your kind words. And as you told that we will try to keep it for a very long.
Right.
Now I will request our ex-president of Raj RSSDI, Dr. Girish Mathur sir, our leader, past president API and Dean ICP, and above all, our own elder brother who takes care of all of us for all the things. I will request Dr. Girish Mathur sir to say a few words of blessing to all of us.
Thank you, Prakashji. Good evening, friends. I am really very happy to be part of this ambitious and prestigious online case-based discussion program, which is running successfully for more than a year. And credit of success goes to the inspiration and support we are getting from our mentor and leader, Dr. K K Pareek sir, and to the energy, dedication, enthusiasm, and efforts Dr. Prakash Keswani, Chairman RSSDI Rajasthan Chapter and Project Director of this program. I salute him for all his efforts and dedication. I also acknowledge and admire the sustained efforts and support by our dynamic secretary, Dr. G D Ramchandani. I welcome all the participants. Your presence is the key to the success of the program. I especially welcome our senior Dr. Arvind Mathur sir, Dr. Puneet Saxena, Dr. Gwalani, Dr. Geeta Arora, and all others who are joining this evening. Apart from this academic excellence, this program is also providing a platform to our young and budding endocrinologists. We are having today Dr. NITESH from Kota, a young endocrinologist from Kota. I also sincerely welcome our panelist, Dr. Sanjay Saran, a very active endocrinologist and associate professor SMS Medical College Jaipur, Dr. Sandeep Tak, senior professor medicine SN Medical College Jodhpur, and Dr. ABHISHEK PRAKASH, very active. I am seeing him for last many programs. He is very active on our platform. He is professor. He is very senior endocrinologist of Manglam plus Medicity Jaipur. So I wish all the best for the success of the program. Thank you so much. Thank you, Prakash ji, for.
Thank you, sir. Thank you very much for your kind words. And now we move towards our scientific program. And I request Dr. NITESH to please start your deliberation. You start your case.
Sir, am I audible?
Yes, audible and visible.
Thank you, sir. Sir, first of all, a very good evening to everyone, and I wish to pay my warm regards to all the stalwarts, my respected teachers, seniors, and colleagues. This is a very important and special moment for me, especially to present a case in front of those who have taught me. So I especially pay my regard to Dr. K K Pareek sir, Dr. Girish Mathur sir, Prakash Keswani sir, and G D Ramchandani sir for giving me this opportunity to present a case in front of this big forum. I also welcome everyone, all the delegates. So should I start my presentation, sir?
Yes, start please.
Thank you, sir. So the case for today is a case of a young male who presented to us with hip pain and diabetes mellitus. So basically, as I understand, the purpose of a case presentation is to benefit in retrospect, to get wiser in retrospect, and to learn from our mistakes. So today I will like to highlight the mistakes made by me and the whole team while dealing with this case. And I will like everyone to learn from what mistakes we have made. So he's a Mr. S, young unmarried Muslim male. He's a resident of UP and a fruit vendor by occupation. He presented to us at the age of 24 years in 2022 with chief complaints of bilateral hip pain for past 2 years. So at the age of around 21 to 22 years, he developed pain in his left hip joint. The pain was insidious in onset and gradually progressive, was mostly located in groin and gluteal region, and was aggravated on hip movements. There was no history of any trauma or any lifting heavy objects. The pain gradually increased in severity and the patient started limping while walking. So he first consulted orthopedician locally. So the patient underwent a radiological imaging, which was X-ray, followed by MRI of the hip joint. We can see that this is the X-ray of year 2020. So 2 years before he presented to us. So we can see that in this X-ray, the left hip joint, the neck of femur appears collapsed, and there is some deterioration in the architecture of the femur. The smooth lining.
प्रद्युमन बॉस आप प्लीज म्यूट कर दीजिए. प्रद्युमन बॉस.
हाँ बॉस यही हूँ.
थोड़ा म्यूट कर दीजिए, आवाज आ रही है आपकी.
Sorry.
So we can see that there is a collapse of the head of the neck of the femur. Also, his MRI was done in September 2020, and we can see that surprisingly, the MRI reveals that there are T1 weighted, in the T1 weighted images, there are hypointensities, not only in the left hip, but also in the right hip. In the T2 weighted image, these are the hypointensities we can see, or also we can see that there is distortion of the neck of the femur, the head of the femur.
Turbulences कहाँ से आ रहा है?
So, and there is collapse of the head of the femur. In the T2 weighted images, we can see that there is a there is a fluid collection in the hip joint in the left side, and also there are hyperintensity, T2 weighted hyperintensity in the hip joint. So these findings, they are suggestive of avascular necrosis of the hip. So diagnosis of bilateral AVN was made, and patient was managed initially conservatively. For AVN, there was no history of any trauma. There was no history of any alcohol use, and also patient denied any use of any steroids or indigenous medication intake, which all these are a common cause of AVN. The patient gradually started walking with support, and his pain continued and progressed to involve right side also. As we have seen that in the images, the right hip was also involved with avascular necrosis. Conservative management was continued with many serial follow-up MRIs. So again, we can see in the year 2021, when MRI was repeated, the head of the femur, the collapse has increased, and the damage to the head of the femur has increased on both sides. So the avascular necrosis of the hip had increased. So because of increase in the severity, increase in the staging of avascular necrosis of hip, he was planned for a hip replacement, for which a pre-operative evaluation was done in October 2021. And this time it revealed that patient was both diabetic as well as hypertensive. His initial blood glucose was more than 500 milligram per deciliter. HbA1c was around 11%. And blood pressure.
ये विमला नाम से कौन बोल रहे हैं? विमला नाम से
Yeah,
कुछ
I'm
जो है
requesting, please
Mr.
mute
Vimla,
others, na?
Dr. Vimla, please mute yourself. Vimla,
केशवानी बॉस सबको अनम्यूट कर दो, सबको अनम्यूट कर दो डॉक्टर नितेश के अलावा। आप करो अनम्यूट। केशवानी बॉस।
हाँ।
अजय can we mute everybody?
अजय ने केशवानी बॉस को दे रखा है लिंक।
अच्छा, इसको म्यूट करना मेरे को आता नहीं है, वरना मैं कर देता।
तो ऊपर जाके उधर अनम्यूट कर दो उनको।
हाँ,
अनम्यूट, सबको अनम्यूट कर दो एक्सेप्ट नितेश के अलावा।
कैसे करेंगे?
अनम्यूट ने म्यूट करो।
सॉरी, म्यूट कर दो सबको नितेश के अलावा।
कैसे करते हैं मुझे आइडिया नहीं है।
अच्छा,
कैसे करते हैं?
पूरा आज
आज वो बर्थडे था ना।
पार्टिसिपेंट में जाओ।
किसमें?
पार्टिसिपेंट में पूरा
हो गया
चलिए,
विमला तो म्यूट हो गई।
So should I continue?
Yeah, please.
So the patient was planned for hip replacement, for which a pre-operative evaluation revealed that the patient was both diabetic and hypertensive. He had a random blood glucose of more than 500 milligram per deciliter, HbA1c of 11%, and a blood pressure of more than 180 by 100 on many visits. So in this 22-year-old male, there was diabetes as well as hypertension, which were both very high, both uncontrolled. So the patient was referred to a physician, and he was started on oral anti-diabetic drugs with the label of type 2 diabetes. He was given metformin plus glimepiride 2 mg twice daily, along with 2 antihypertensive drugs. But as it was not controlled, the doses were gradually up-titrated. But because of uncontrolled hyperglycemia and uncontrolled hypertension, patient could not undergo surgery for next few months to around 1 year.
Dr. Nitesh, he was not earlier known as a diabetic?
No, sir, he was not a diabetic earlier.
No other systemic illness for producing this avascular necrosis of hip?
Sir, he did not had any history of taking steroids, no history of trauma, and no history of alcohol intake, which are the most common causes of AVN.
Dr. Nitesh, can you elaborate on general physical
Presented first with the avascular necrosis of head.
Yes, sir.
Right.
Yes, sir.
Okay, interesting.
I am not able to change my slides now. Something has happened. I am not able to change my slides.
Okay, so Can't you move further?
I think you can exit and reshare. That will be good.
Okay, sir. I'm not able.
Meanwhile, Nitesh, Dr. Tak here. Hello.
Hello. Yes, sir.
Yeah. Can you
नीतीश इसको पीछे ले लो, 2-3 स्लाइड पीछे लेके फिर करके देखो.
सर ना आगे हो रही है ना पीछे हो रही है. I am stopping just a minute.
हाँ, तो एक बार यहाँ तो एग्जिट करके फिर से करना पड़ेगा. फिर से करिए, हो
Yes,
जाएगा.
yes, sorry.
नीतीश को वापस से को-होस्ट बना दीजिए आप.
Yes.
That will help us basically. अच्छा Nitesh, by the way, about the general physical examination of this patient, na?
Yes,
How
sir.
his faces?
Yes, sir.
General physical examination of this patient.
Yeah,
Sir,
that's very
I
important.
will come on it later on, sir.
Yeah, BMI and general physical examination.
Yes, sir. I will come on it, sir. So the patient, sir, this is the history in retrospect when he came to us in 2022. This is the history from 2020 to 22. So after which I will present the examination, sir. So the doses were uptitrated, but it was uncontrolled. So in April 2022, the patient first consulted orthopedic department at our center and then was admitted for hip replacement, and a referral was sent to endocrinology for uncontrolled hyperglycemia. So this is now a routine habit after COVID, that most of the times consultations are done without physical presence of patient. And that was our mistake, that we did consult based on the file, based on the records of blood glucose monitoring only. And twice the consultation was done based on glucose charting only. His HbA1c was 9. Blood glucose readings fluctuated at around 200 to 400. He was initiated on basal bolus insulin regime and was uptitrated, but still blood glucose was not properly controlled. So this time patient was seen and examined by me personally, and the history was reviewed. So history revealed that there was a gradual weight gain of 20 to 25 kilograms over last 4 years, which was associated with recurrent fungal infections also on the skin for last 2 years. And the patient gave history that he consulted dermatology also multiple times for the fungal infection. He also had history of spontaneous bruises over body for past 1 year, along with hyperpigmentation of both skin and hands, skin of hands and foot. And he thought that it is related to the occupation. So he never mentioned it and highlighted it to the physician or the consultant doctor. He also had proximal muscle weakness for last 1 year, but he also thought that because he is having pain, so because of that he is having some weakness. But there was proximal muscle weakness in lower limbs more than upper limb and bilaterally for last 1 year. And also on asking, he gave history of polyuria, polydipsia for past 8 months, along with unintentional weight loss of 5 to 6 kgs before presenting to us only. Also, for last 2 to 3 years, he was having decreased libido and erectile dysfunction, but did not mention it. And as he was unmarried also, so he did not bother about it. So history also revealed that the patient, even after asking many times, denied any steroid intake in any form. Also, there was no history of headache, vision disturbances, any history of cough, dyspnea and flushing episodes, or any abdominal pain or lump palpable in the abdomen. There was no history to suggest any obstructive sleep apnea. There was also a past history of nephrolithiasis. So all these histories are very relevant, that he consulted dermatologist for a fungal infection. There was a history of nephrolithiasis for which he consulted, was managed conservatively. Also, there was a family history of diabetes mellitus present in mother, and there was no history of similar illness in any family member. This family history of diabetes in mother usually makes us to make compels us to make a diagnosis of type 2 diabetes in any obese individual who is coming to us. There were no addictions, and also he consumed mixed diet but had sedentary lifestyle due to his illness. On examination,
going for the examination, could you get something in history which can say that this diabetes was present for a very long, because he has some complications also like vascular necrosis of.
So even on asking, he complained of osmotic symptoms for past 8 to 9 months only. Even when his blood glucose was detected to be more than 500, he denied having any major osmotic symptoms except having the fungal infection on body. And also he did not had any weight loss earlier. Earlier he was having weight gain, but for past 8 to 9 months, he had an unintentional weight loss of 5 to 6 kgs before coming to us.
That may be because of this episode of hyperglycemia.
Yes, sir, that could be related. So when we examined the patient, he was conscious oriented. Blood pressure was 146 by 96 mm of Hg, which was on 4 antihypertensive drugs, including a diuretic. Pulse rate was 96 per minute. His BMI was 32 kilogram per meter square and a waist circumference of 119 centimeter. And clinical stigmata of Cushing disease was present. So this is the thing that we missed while doing teleconsultation only based on the file and glucose reports. So there was facial plethora, there was moon face, periorbital swelling and chemosis was there. I will show photographs also. There was buffalo hump, hyperpigmentation of knuckles and toes, thin skin was there. Purple, some stretch marks were there, but they were not classical. They were less than 1 centimeter. Spontaneous bruises were evident, and there was a generalized tinea corporis. Because of erectile dysfunction and low libido, we examined the testes, which were 15 to 20 ml bilaterally, and there was no genital mycosis. So this is the photograph of the individual. We can see there is some facial plethora. There is rounding and mooning of the face. The ears are not visible properly. And also we can see there is a gross hyperpigmentation, both of hands as well as legs, which the patient ignored and thought it is because of his work. He worked as a fruit vendor. He used to deal with some chemicals also. So he thought that it was because of some chemicals. We can see then on abdomen, there are some stretch marks, but they are not classical more than 1 centimeter dehiscent purplish stria, although they were present, and there were many hyperpigmented areas along with generalized tinea corporis. In systemic examination, the respiratory and CVS examination, per abdomen examination was normal. In CNS, he had emotional lability. He was depressed. Proximally, the power was 4/5 at hip and shoulder joints, and rest of the systemic examination and examination of the spine was normal. So before going to investigation, I wish to summarize that he's a 24-year-old young male presented to us with spontaneous bilateral avascular necrosis of hip, had obesity, young onset diabetes mellitus, and resistant hypertension with features suggestive of Cushing syndrome, which is likely to be ACTH dependent, especially because of the presence of hyperpigmentation on history, as well as an examination, without any history of exogenous steroid use, and also having a positive family history of diabetes mellitus. So these are the investigations. When he was admitted to our institute, he had some anemia. HB was 10.5. There was neutrophilia. Leukocytosis was not there, although eosinopenia is there. And the kidney function tests were normal. We can see that there is hypokalemia. So potassium was 2.93. SGOT, SGPT were mildly on higher side. The random blood sugar was 400 milligram per deciliter with an HbA1c of 9%. And look at the lipid profile. His LDL levels are markedly high, 203. Also, his ABG revealed a metabolic alkalosis. So now, when looking at it, our young patient who presents to us with hypokalemia and has metabolic alkalosis. So the possibility of hyperaldosteronism or increased activity of aldosterone receptor has to be thought. So even if we go in this direction and combine it with hyperkalemia, we can reach that there is a possibility of hypercortisolemia because the cortisol also acts on the mineralocorticoid receptor. This much dyslipidemia, the LDL level of 203 is usually found in either primary hyperlipidemias or secondary disorders like hypothyroidism or Cushing's disease. So this lipid profile also directs us that there is some secondary cause which is leading to such high dyslipidemia, and only diabetes and obesity are not the primarily culprits. Coming to further investigations, when a hormone profile was done, we can see that the T4 levels, they were low with TSH of 0.7. The LH and FSH in a 3 pooled samples, they were also low with a low testosterone suggestive of hypogonadotropic hypogonadism as well as secondary hypothyroidism. So this directs us that there is some issue with the pituitary. And then we did evaluation for Cushing syndrome as per protocol, and ATM serum cortisol was done to rule out secondary adrenal insufficiency due to exogenous steroid use, but it was 33 microgram per deciliter, which was not suppressed on giving 1 milligram of dexamethasone, was not suppressed on doing a low dose dexamethasone suppression test also. A baseline ACTH levels was 288 picogram per ml. So these are very high levels. Usually when we see a level of more than 15 to 20, we call it ACTH dependent. It is said that when the levels are more than 90 picogram per ml, the possibility of an ectopic source of ACTH is there. And also on high dose dexamethasone suppression test, Usually in pituitary disorders, we expect there should be a more than 50% suppression, but in this case, it was not there. So the findings are contradictory. On one side, we are finding some features to suggest pituitary disease, but on the other side, some features are there to suggest ectopic source of ACTH. But we are sure that there is endogenous ACTH dependent hypercortisolemia.
Dr. Nitesh,
Yes, sir.
it is that sudden onset diabetes,
Yes,
sudden
sir.
development of Cushing picture, and hypokalemia.
Yes, sir.
It's a known thing for ectopic ACTH also.
Definitely, sir.
So with
Yes,
that
sir. So
also
yes, sir. That is why the possibility of ectopic more than pituitary has been mentioned here, sir. But the features, hypogonadism can be there in any hypercortisolism. So it does
problem
not.
is that problem
Yes,
is that.
sir. And T4 can be low because of sick euthyroid also. So that possibility also has to be kept, sir.
Okay.
So coming to further investigation, a DEXA scan was done, which revealed osteoporosis. So this was a secondary osteoporosis. And an MRI of cellular and supracellular region was ordered, which revealed that there was a large pituitary macroadenoma, which was extending to supracellular region also, which was invasive. It is invading bilateral cavernous sinus, NOS4 staging. We can see that there is beautiful, and it is forming a figure of 8 also, macroadenoma. So it was reported as pituitary macroadenoma with supracellular extension and complete encasement of intracavernous segment of bilateral carotid arteries, which was NOS grade 4 bilaterally. Also, as a protocol, whenever we suspect ectopic, we also get a CECT chest and abdomen also. Although in this case, when we found a macroadenoma, we had a diagnosis of pituitary Cushing disease only, but also a CT chest and abdomen was done to search for any ectopic source if there is evident. And we can see in these, you can see the bilateral adrenals. These are very much enlarged. There are nodular also, and it was reported as having bilateral adrenal. So sometimes in a case of this Cushing's disease, if we falsely do a CECT chest and abdomen first, then there can be a false impression that the adrenals are the source of a cortisol. But in this case, this is the secondary enlargement of the adrenals because of high ACTH. There was a hepatomegaly also, and AVN was also visible. For the causes of secondary hypertension, renal artery Doppler was also done, which was normal, and USG kidney revealed a bilateral nephrolithiasis, which is also a feature of Cushing's disease. Also, his 2D echo revealed a concentric LVH with ejection fraction of 60%. So the final diagnosis after investigations was locally invasive NOS4 pituitary macroadenoma with ACTH-dependent Cushing's disease with secondary hypothyroidism, hypogonadism, bilateral avascular necrosis of hip, secondary diabetes, secondary hypertension with obesity, dyslipidemia, NAFLD, left ventricular hypertrophy, secondary osteoporosis, and nephrolithiasis. Almost all of them attributed to just a single disease of Cushing's disease, the endogenous hypercortisolemia. So, as per protocol, patient was...
Before going for the management,
yes,
we should
sir.
try to discuss the case also.
Yes, sir.
Dr. Saran, Dr. Abhishek, you will like to ask something?
Nitesh, I would like to just press a point that after your history and not going for the examination, can
Yes,
we
sir.
know beforehand, because you highlighted hyperpigmentation very much. So can you tell, does hyperpigmentation help us to differentiate whether it is an pituitary dependent or like an ectopic source? And what is the reason for hyperpigmentation in such case? Because ACTH will be high in both the cases. So is there any like rapidity or something clinically how we differentiate?
Sir, to differentiate between pituitary and ectopic sources, usually the rapid onset of the disease along with weight loss. Usually Cushing's disease present with weight gain. In a patient with ectopic source, usually there is not much time for weight gains. They usually present with weight loss. There is uncontrolled hyperglycemia, hypokalemia, severe proximal myopathy. Hyperpigmentation can be present in both the cases, but it is usually more evident in cases of Cushing's disease because it gives more time. There is usually a period of 2 to 3 years before diagnosis. So there is, and it is an indolent course. So there is more hyperpigmentation in cases of Cushing's disease. But Since the ACTH levels are very, very high in ectopic, so hyperpigmentation is present there also, and we cannot differentiate just on the basis of hyperpigmentation. The hyperpigmentation is occurring because the ACTH is going and acting on the melanin receptor, MC2R receptors, and causing the hyperpigmentation, increase in the melanin secretion in the skin.
Yes, and I think it's not basically the only the clinical presentation of hyperpigmentation. We have to see in totality what is the rapidity of onset, whether proximal muscle weakness is there or not. Because in cases of ectopic, the levels are high, the presentation is short. So chances of hypokalemia and muscle weakness because of hypokalemia will be more. So they are better clinical markers rather than hyperpigmentation alone.
Definitely, sir. But
so yes, that point
Nitesh,
is
clinically,
rightly
it
said.
seems to be more like with your investigation, it seems more like that of the ectopic ACTH, except that
Yes,
we
sir.
found a tumor in the pituitary.
Yes,
So
sir.
relying on just that one tumor which is in the pituitary, cannot be other some tumor ectopic ACTH also.
Sir,
This
for
tumor
that
may be,
only, yes,
yes.
sir, definitely.
So that we
keeping
have
that,
to confirm by some other test. After high dose, we can go for the very high dose or initial petrosal sinus sampling to confirm that this ACTH is coming from the pituitary.
sir, definitely we can go for it. But if, we did a CACT chest and abdomen, and there was no evident source of
Okay,
ectopic
you
ACTH.
excluded that by imaging only. Yes. That.
Yes, sir. So since there was no source of ectopic ACTH, CACT chest and abdomen, and there was a glaring big pituitary macroadenoma, so that is why we thought, and we do not usually have the facility of AVS at our center, and also we do not IPSS at our center. For IPSS, sir, whenever the tumor is between 0.6 to 0.9, when there is a confusion, then only we usually go for it. But in this case, there was a large pituitary macroadenoma, so probably that is why we did not
Yes.
go ahead with it, sir.
Usually kissings we find very small adenomas.
Yes, sir. And
Yeah,
also,
Dr.
sir, have
Dr.
two diseases like a pituitary macroadenoma along with the ectopic source, so two rare diseases to be simultaneously present, the possibility was low, sir.
Less, definitely.
Yeah, Dr. Nitesh, Dr. Tak from Jodhpur.
Yes, sir.
Just one question. Not question, a very excellent, interesting case. Can you just highlight, looking at the first 2-3 slides of first initial history, what were the red flags that suggested that this is not a type 2 diabetes? There were red flags initially also that suggested that it is not a simple type 2 diabetes.
Sir, yes, sir. Sir, definitely the age of onset. First,
Yeah.
although nowadays, sir, we
Now
are
we see
getting
that.
type 2 diabetes in obese young individuals also in the age of 20 to 30 years. But still, the age of onset was atypical. Secondly, the presentation with bilateral hip pain and avascular necrosis. Sir, this is usually
Yeah.
avascular necrosis tells us that there is some other reason, either an exogenous steroid or some endogenous hypercortisolemia.
And
Sir.
third thing, he had a secondary resistant hypertension.
Yes, sir.
He had
Yes, definitely, sir.
So that's again a red flag that there's something wrong with this. And even his X-ray pelvis, if you see that X-ray, you will clearly make out that this patient is very obese.
Yes,
even if you haven't seen the patient in person, if you see this X-ray, you will clearly make out this patient is very obese and there has to be something for this AVM. So these are, I think, red flags in these patients that we need to see whenever we see a patient or make a presumptive diagnosis of type 2 diabetes.
Yes, sir.
Yeah, otherwise it's very excellent. Yeah.
Thank you, sir.
Please go ahead.
Nitesh, there is one thing. What was the ophthalmic examination like?
Sir, yes, sir. Yes, sir. Sir, I did not mention it. On confrontation test, it was normal. There was no visual field defect. Formal perimetry was not available at that time, so was not done with this patient, sir.
Dr. Nitesh, asked what happened later on, as it was having patient was having big this macroadenoma was there. That macroadenoma must have been removed. Then later on,
yes, sir. Actually, I was coming to the management only. There are few more slides, sir. So should I go ahead with it?
I interrupted in between,
yes,
so
sir.
we can please.
Yeah, because actually in Cushing, macroadenoma is very rare. Na ACTH yes, we see only very small tumor, and most of the times not see any tumor in the MRI.
Yes, sir. So
10%
of the cases are macroadenomas, sir, usually.
Yeah.
Yes,
So
Had it been in the Jaipur, we must have gone for the inferior petrosal sinus sampling, which is possibly not available in the Kota.
yes, sir.
So that would have given more clear picture.
Yes. Sir, so the patient underwent TNTS, that is the transnasal transsphenoidal resection of macroadenoma in June 2022. Perioperatively, the low molecular weight heparin was administered for DVT prophylaxis. The patient had steroid withdrawal symptoms post-operatively initially. He had skin exfoliation and nausea vomiting, which were expected. He was given hydrocortisone replacement for first 5 days. Insulin and antihypertensive requirement decreased by around 40 to 50%. However, post-operatively, day 7 serum cortisol was done after stopping hydrocortisone for 24 hours, and it was 64 microgram per deciliter, which was suggestive of residual disease. So it was started on medical therapy for Cushing's with ketoconazole and was gradually uptitrated to up to 1600 milligram per day. But since the disease was not adequately controlled on medical therapy and follow-up imaging, which I'll show later, revealed a residual tumor as expectedly because it was a NOS4 tumor. So nobody could have attempted complete removal. So there was residual tumor. Patient was referred for radiotherapy, which he underwent external beam radiotherapy 50 gyri in August, September 2023. Post radiotherapy over next few months, his 24-hour urine cortisol normalized and even was low, and his all the anti-diabetic and anti-hypertensive drugs could be stopped. So this is the follow-up imaging. We can see that still around the cavernous sinus, there is presence of tumor tissue. These are the post-operatively 3 months image. We can see that initially there was a lot of hyperpigmentation, and even after debulking of the tumor, even when there is not complete control of the Cushing disease, the hyperpigmentation started resolving. The marks on the abdomen, they started improving. So coming to the follow-up investigations, we can see that the HbA1c, initially he was on insulin, then insulin was stopped in December 2022. So around after 6 to 7 months of surgery, his insulin could be stopped and he was managed on OADs only, including sulfonylureas and metformin. And we can see that in October 2023, gradually as the disease improved after radiotherapy, his oral anti-diabetic drugs could also be stopped. So this is a very important point, that whenever we find some secondary cause, even for hypertension, even for diabetes, if we remove that secondary cause, the disease can be cured. I will like to use the word cure in this case because the secondary diabetes, it gets cured when the cause is removed. So we can see that without OADs, he is currently maintaining an HbA1c of 5.4%. And the serum cortisol levels, which were on post-operatively day 764, they have gradually remained stable until radiotherapy, and after radiotherapy, the serum cortisol 8 a.m. in the morning was 5.37 with a low 24-hour urinary free cortisol. So the dose of ketoconazole was decreased. And we can see after a post-operatively 1 year, 6 months, the patient's erythema, the patient's hyperpigmentation, all the marks, the tinea corporis, the stria, they have improved. Patient has also lost some weight, but then again regained the weight because he underwent surgery for the avascular necrosis and was on bed rest for a few months. So we can see that post-operatively 2 years, his profile has improved. So he underwent left total hip replacement after establishment of eucortisolemia in May 2023, along with conservative management for right AVN. Replacement for hypopituitarism and bisphosphonates for osteoporosis are continued. So I will like to present some slides on discussion. So the important points are that this is a case of young onset diabetes with obesity and with also positive family history of diabetes in mother. It is not uncommon nowadays. We are seeing a lot of patients with this profile, but it is always not type 2 diabetes. This is the key message. There are causes of secondary diabetes, especially acromegaly and Cushing. They should be considered and searched for all the patients of atypical diabetes in young age. I remember one case also, a young female presented with uncontrolled hyperglycemia, was given a label of type 2 diabetes only because she was obese. She had some hirsutism also, so PCOS was considered. And gradually in follow-up, I noticed that there was some lip thickening, there was some hoarsening of voice, there were some subtle features of acromegaly, and when we investigated, we found there was a large pituitary macroadenoma with subtle features of Cushing presenting with diabetes. So both Cushing and acromegaly should be considered when patient presents with weight gain and diabetes in a young age. So coming to some literature review also. So among diabetes mellitus, which presents in young adults, so what is the proportion of different diseases? So this is a study which I took from India only. This is a recent study in 2019, but it mentions that both type 1 and type 2, they are equally frequent now, around 40% in patients with young onset diabetes, less than 40 years of age, followed by FCPD, followed by MODY, mitochondrial diabetes, and flatbush diabetes. And I did not find any literature which says that what percentage of patient with diabetes in young patients in India is comprising of Cushing's or steroid-induced diabetes or acromegaly. So probably these are very rare, but still they are present and we should search for them. So coming to this important article, how many patients of type 2 diabetes, they have Cushing syndrome. So when the patients of type 2 diabetes, they were screened for Cushing syndrome, especially in those who had uncontrolled hyperglycemia. So we can see that this is one of the largest study comprising 800 patients, and just 0.6% of the patient in the overall series, they were found to have a definite diagnosis of Cushing disease. But this is also not a small number. So probably in 1,000 diabetes patient, if we will see, we will find around 8 to 10 patients who will have endogenous hypercortisolemia, and we have to be vigilant to find out this needle in the haystack. So coming to reverse prevalence of Cushing in diabetes, this is again the same thing, prevalence of Cushing in diabetes. These are the many studies. One of the two largest studies, 803 patient, 903 patient. We can see that the prevalence has varied. If only ONDST is chosen as the criteria, the prevalence is very high, which is probably because of false positivity. But around some patient, which is less than 5% or less than 10%, I should say, they have these features of endogenous hypercortisolemia. Coming to the glucose metabolism abnormalities in a patient of Cushing disease. So if we think reversibly that among all patients with Cushing, how many have glucose abnormalities in the glucose metabolism? So this is a good review article from JCEM, and we can see that around 30 to 50% patients of Cushing disease have type 2 diabetes, and even around 70 to 80% will be there if we combine impaired glucose tolerance also. So there is high prevalence of diabetes in Cushing. There are n number of reasons for it. The predominant being there is increase in the gluconeogenesis and hepatic glucose output, along with the insulin resistance which is created by cortisol. Also, the secretion of insulin from pancreas is also decreased because of beta cell apoptosis and impaired beta cell function. So coming to an important aspect, the medical therapy of Cushing in a patient of diabetes. So all the medical agents which decrease serum cortisol levels, they have been found to have beneficial effect on glycemia, because to us ketoconazole is most frequently available, most frequently used. We have most experience with it, so it is commonly used. However, mifepristone, which is a glucocorticoid receptor antagonist, is especially useful in patients with diabetes. And somatostatin analogs, the octreotide and pasireotide, they can have adverse effect on glycemia. And in fact, around 70% patients with pasireotide land up with hyperglycemia when given for Cushing. Coming to anti-diabetic therapy in a patient who has Cushing disease. So first line treatment, it should include drugs that increase insulin sensitivity, such as metformin, or drugs which increase postprandial insulin secretion, such as DPP-4 inhibitors, GLP-1 receptors, sulfonylurea, glinides. Anything can be used except thiazolidinediones. So it is important to know that thiazolidinediones are not recommended as a first-line option because they increase the risk of heart failure. Since these patients have secondary osteoporosis, thiazolidinediones also increase the bone loss and increase the incidence of fractures. Also, I would like to comment that it is not written in the review of literature about SGLT2 inhibitors, but because there is a rampant use of SGLT2 inhibitor, I feel that since these patients are immunocompromised, their use in patient of Cushing's will increase, definitely lead to increase in the UTI, so should be avoided. And in any acute setting, especially when patient presents with severe disease, catastrophic Cushing, insulin is the treatment of choice, either infusion or basal bolus regime. Coming to last few slides, because it is a very atypical case, and I want to highlight the atypicality of AVR in Cushing's. You all will be surprised to know that corticosteroids, exogenous glucocorticoid, they are the most common cause of avascular necrosis of the femur in the reviews in the various studies, followed by alcohol abuse. So chronic alcohol intake also predisposes to this avascular necrosis. These are the non-traumatic causes. Overall, trauma is the most common cause. In non-traumatic, glucocorticoid are the most important causes. And the incidence of AVN is around 6 to 7% in patients who have a corticosteroid dose of more than 2 grams of prednisolone equivalent per day. An additional 10 mg per day increases the rate of AVN by 3%. But very importantly, it is rare to find avascular necrosis of hip in endogenous hypercortisolism, and till date only less than 20 cases have been reported worldwide, out of which 80% patients are female, and most of them have usually had unilateral AVN. So this case is atypical because we have male who present with endogenous hypercortisolemia, a pituitary macroadenoma, and presenting with bilateral avascular necrosis of the hip. So at last, to summarize, the first and most important point which I want to emphasize, there is no alternative of clinical examination. And nowadays, because even we do teleconsultations, the patients send us report, we send them prescription. The physical examination, it usually lags, and there is no alternative for it, because we can pick very, very important clues on physical examination, especially for atypical cases like this. And young onset diabetes with obesity and hypertension, it is very common nowadays, but it is not always type 2. Cushing should be kept in mind. Uncontrolled hyperglycemia and uncontrolled hypertension, along with hypokalemia, severe dyslipidemia, they are biochemical clues for presence of hypercortisolism. And very importantly, whenever we have a secondary cause, it can be cured. So diabetes in Cushing can be cured if the patient goes in remission. And AVN is a very rare presentation of endogenous hypercortisolism. Thank you. I wish to acknowledge my respected teachers from Safdarjung Hospital, because I have just come 3 months back to Kota. So this case has been taken from my previous. This has been followed by me only in last 3 years. And sir, I presented a poster on this case only in SECon, which was conducted in Jaipur. And I wish to thank patient also. Thank you.
Thank you, and congratulations, dear Dr. NITESH.
Thank you, sir.
Our very good case bringing to all of us, and your presentation was also really very impressive and good, and your management was also very much right. And we could see a case which was neglected. Most of the Cushing's comes in the microadenoma stage, and he was neglected and presented with the macro, with the avascular necrosis and diabetes. It was really a good case. Dr. Sanjay Saran, will you like to say something to us? Your comments?
It was a really very nice case and excellent presentation, as it is very rare to see the Cushing with macroadenoma. Many times we also encountered with such kind of macroadenoma, but actually it's very frustrating. We remove the tumor, but still the Cushing persists. So persistent Cushing is there. So later on we do the IPSS, and we just came to know that something extra is there, which is secreting this hormone. So in such kind of patients, we usually do resurgery, or sometimes we do radiotherapy, or sometimes in one case we have done the bilateral adenectomy just recently, because we have removed all that most part of the pituitary, but still ACTH is very high in that case. So this was really very nice case to see the big, very big, this macroadenoma with Cushing. ACTHoma. So really very nice to see this case, and it was very beautifully presented by Dr. NITESH. So thank you very much.
Dr. Sandeep Tak, Dr.
Yes, sir. Yeah, I have already passed my comment previously. Excellent presentation, Dr. NITESH. Excellent case of the secondary diabetes, secondary hypertension. Hopefully, we would be seeing much more cases like that. Good.
Thank you.
Very good case presentation, NITESH, and I think it was very well backed up. I didn't see the follow-up part, but it was I was very happy to see that finally the diagnosis and management worked up for the patient. Just want to add one point that in the initial evaluation test for the Cushing syndrome, for the general benefit of all, I am saying that the 8 AM cortisol for this patient was around 33. So many a times when we evaluate in our clinical practice as physicians or as endocrinologists, when the patient comes out for the first visit and we order an 8 AM cortisol, it may not be necessarily that every time the cortisol will be high. So I think doing at least not ordering only serum cortisol 8 AM will do. At least we should do a 1 mg overnight dexamethasone suppression test before making the patient go away, because many times we will be doing window shopping. And many a times in Cushing's, we can have normal cortisol levels also. It's not necessarily that we would have hypercortisolemia in every visit. So I think 1 mg ONDST is very much test if we want to rule it out. That's it.
Thank you.
Any other comments?
I think
Dr.
this
G D Ramchandani?
Thank
Or-
you, Keswani sir.
Yes.
Namaskar sir.
Namaskar.
First of all, I would like to congratulate Dr. NITESH for a wonderful presentation, a wonderful case, and he is doing wonderful job, wonderful in Kota, and definitely case was very interesting, and finally it was cured. I would like to say one thing that online consultation was very good in the time of COVID, but sometimes we are missing a lot of things. That patient was remain on OHS for I think for 1 year, as Dr. Nitesh told. He was taking glimepiride metformin for 1 year with 500 milligram blood sugar and all these complications. So ideally, physical examination and physically patient until you are not seeing the physically, you cannot miss the diagnosis for some time, for a long time. So that message also should be conveyed to such patients, and early diagnosis and cure of the disease with this case. Excellent presentation.
Thank you, sir. Thank you.
But luckily today, Dr. Girish Mathur sir is also with us. We would like to have your comments also, sir.
Dr. Prakash, thank you very much for getting me in, and it is my privilege to meet sir also, K K Pareek sir, and all the youngsters. I think this case again highlights the importance of general physical examination.
Yes, sir.
I think looking at the patient itself will give you a clue about it. So this again reiterates the importance of general physical examination, and that is probably very important in all endocrine cases also. Thank you.
Definitely, sir. Clinical examination again comes further top. And this patient was consulted initially for the blood sugar only on the telephone. And as soon as we see the patient, and many of the times we get phones for this, and when we ask them to send the patient, many of our senior colleagues get irritated. Why do you want to see the patient? Ye sugar hai, iska ilaaj kya karna?
And congratulations, Nitesh, for excellent case evaluation and management for all. Thank you. God bless you.
Any other comments? So today it was a very good case learning by Dr. Nitesh and good discussion by all. And a good number of our seniors and mentors have joined us for blessings. At the last, I would like to thank Dr. Pareek sir, Dr. Mathur sir, Dr. Mathur sir, Dr. Gwalani, Puneet, and Dr. Geeta Arora, which always joins all the courses in time, and many of other colleagues who have joined and have given their inputs. And thank you very much, sir. Thanks a lot to all of. Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
And we also welcome Dr. Parth Jetwani, is another endocrinologist of the Kota. He recently joined. And
Dr. Parth, yes. Invite him for the next case only.
I think he is
yes. Dr.
Thank you, sir. Thank you so much for the invitation.
Doctor, yes. Parth, you have to prepare case for the next third Thursday.
Sure, sir. I'll do that, sir.
Yes. I also request from Dr. Puneet Saxena, Vice Chairman of RSSDI, with their comments also.
Good evening, everybody. I was listening the case silently, and I can see Pareek sir, as usual, patronizing all the academic mates. I can see Dr. Arvind Mathur sir and Keswani sir has taken this journey very nicely over last 1 year, and Dr. G D Ramchandani and everybody from Kota. Dr. Nitesh, you presented the case very well. And with the diabetes in young and basically secondary diabetes workup is very much required. They are often missed. And as rightly said by Arvind Mathur sir, that clinical examination give you clues basically. And that often is missing. As soon as you see a diabetic patient, you just start treating the blood glucose values rather than finding the root cause. So that is also very essential. and this is a very nicely worked up and presented case. So thank you very much.
Thank you.
Nice comments, Dr. Puneet. The last, I will like to thank you all for your cooperation and participation. Again, we will meet on the third Thursday of the next month, and Dr. Parth will be presenting it.
I think before concluding, final comments by Dr. K K Pareek, sir.
Pareek sir, the main, sir.
There was an article in Jaipur, funeral of clinical examination.
Yes, that is must, sir. Sir, many of the time in the evening we get letter from the Janana Hospital and Mahila Hospital with the blood sugar reports only, no patient, and we have to write down the insulin. Clinical examination is must.
Sir, you are muted.
Unmute करें sir.
Unmute कर ले.
Excellent presentation by NITESH. I have heard him before also.
Thank you, sir.
Dr. Parth is also a very intelligent endocrinologist, has come to Kota and started his career. And we thank you very much, Dr. Prakash Keswani, for giving him a chance to present his case in the next Thursday CME. As Dr. Arvind Mathur and Dr. Prakash Keswani said, the clinical examination is the most important. And for that, we are organizing a national conference of Indian Association of Clinical Medicine based on clinical examination. So at Udaipur on 26th and 27th September at Udaipur. Dr. D.C. Sharma is the organizing secretary, and Dr. B.S. Baum is the organizing chairman. So I request everyone to get registered yourself. We all know that it's Udaipur is a great tourist destination, and we have got a chance of taking blessings from our Srinathji. So I hope you will all register for Udaipur conference. Thank you very much.
Thank you, sir. Thank you very much.
Thank you, sir. Good night.
Bye-bye. Sir, again, the season of conferences is starting. First we have SC
अब तो पूरे साल ही हो गया.
हाँ, sir.
Every year, हर महीने में 2-3 और फिर ऑनलाइन और चालू होगी.
Online.
ज्यादातर एंडोक्राइनोलॉजी की होती हैं.
हाँ, तो हर बार ये
ज्यादातर एंडो की होती हैं.
पुनीत सक्सेना जी की ये आ गई, BP कौन आ गई,
ब्लड प्रेशर की.
फिर इसके बाद उदयपुर की हो गई, उसके बाद फिर श्रीनाथ जी वहाँ अपने क्या है वो अपने
रजनीश सक्सेना की आ रही है सर. रजनीश सक्सेना की.
संजीव महेश्वरी करा रहे हैं स्टेट कॉन्फ्रेंस. तो अब कॉन्फ्रेंस का ये ठीक है. तो फिजिकल कॉन्फ्रेंसेस और ऑनलाइन कॉन्फ्रेंसेस तो देखिए ना, अब सब आप लोग कितने ग्रेट लीडर्स हो गए डिसेमिनेशन ऑफ नॉलेज के, हर जगह नॉलेज फैला रहे हैं. तो इट्स रियली ग्रेट थिंग.
That is all because of your inspiration.
जय हो राजस्थान.
जय हो राजस्थान.
जय हो राजस्थान.
All inspiration. सर मुझे अच्छी तरह याद है 1995 में आपने उस टाइम कुछ भी नहीं होता था ग्लाइनेस की 25 पैसे की गोली के अलावा. And you used to manage conferences at Kota. And we used to come there.
राइट. पहले हमें याद है हम बेनेडिक्ट सॉल्यूशन से शुगर का एग्जामिनेशन करते थे. ब्लड शुगर नहीं होती थी. 67-68 में ये ग्लाइकोमेटफॉर्मिन वाज दी ओनली ड्रग अवेलेबल. उस जमाने में ग्लिमक्लोराइड और ये दोनों ड्रग होती थी. तो फिर बीच में भूल गए लोग वहाँ ग्लाइकोमेट को, इसको मेटफॉर्मिन को पता ही नहीं चला कहाँ गायब हो गई, और फिर वापस ऐसी आई जो फिर अभी तक चल ही रही है.
अब तो नंबर 1 चल ही रही है सर.
चलिए, थैंक यू डॉक्टर.
Bye sir. Thank you very much to all. Thank you sir.
Thank you, sir. Thank you.
Bye bye everybody. Bye bye.
Good night.
Bye bye.
Good night. Thank you so much, Prakash.
Bye bye DDV.
Thank you, more. Thank you.
Bye bye.